So I'm going to go ahead and do some of the data slides on the Venetoclax, and then we'll have any additional discussion points that may emerge after that. Okay, so the study, there are two studies. Both of them are phase 2. There are two phase 3 studies, actually both near completion. One is completed, one is near completion, but we don't have any data to show from those. So the two phase 2 studies, the one I'm going to discuss is the azacitidine or decitabine. It was basically an HMA combination with venetoclax. This study started about 4 years ago, and this was a study that was designed for elderly patients, but also those who are not fit or considered not fit for your traditional induction using a cytarabine anthracycline based approach. And the phase 2 study did not have extremely strict criteria. It was left more to the treating physician, considering them as the expert to make that decision on who they thought was a good candidate. But the phase 3 does have more strict criteria called the Ferrata criteria to select patients who really would be considered unfit. The other exclusion criteria, and something that I think already was mentioned by Dr. Rizzieri and McCloskey, is that the white count is important. You don't want to give venetoclax to somebody with 50,000 and test the waters, because we actually have seen tumor lysis in a couple of patients when you treat large numbers. It's rare. It's not the frequency has been shown in CLL, but it can occur, so I would be very careful. The dose of AZA and decitabine were standard doses. Venetoclax was given in a ramp up here, 100, 200, 400. This was in the phase 1-2, so azoles were not really allowed on that study. I think most people are now using azoles, and capping it, I think 100 with POSA is reasonable, and 200 with FORI or with Cresemba are probably reasonable options. So here we have the slide that has generated, rightly so, a lot of excitement. You see response rates in this population of 60 plus in the range of 70 to 75%, with a large number of those being true CRs. So to put this in perspective, if you look at single agent AZA phase 3 data that was presented by Dr. Dombre, and the single agent decitabine phase 3 data from Dr. Kantarjan published many years ago, the response rate CR/CRi are 20 to 28%. So this was not really double, it was almost triple the response rate. So people were quite excited about this even before we knew the survival. This is the data showing only the people who got 400 ven. There are actually more patients on the study, there are 220, but this is the 115 who got the FDA approved dose of 400 with the HMA, whether it was AZA or DAC. And as you can see that most of these responses, actually it's not shown here, but they occur early. This was the second thing that people were excited about after seeing the response rate, was that it was happening within 29 days. So all of you who have used hypomethylating agents know that it takes usually 2, 3, 4 cycles, but here the median time was actually 1 cycle, so there was definitely a qualitative difference in the response. On the next slide, we see the responses across molecular and cytogenetic groups and de novo and secondary. Basically, a 10,000-foot view here is that it didn't really matter. The response rates were quite similar, between 60 and 80% in different cytogenetic and molecular group. Even in secondary AML, numbers are small now, but you have a pretty good response rate. With time, there's more data that we're not going to go into detail, but it does appear that TP53 and FLT3 patients, they don't seem to do as well when it comes to survival and duration of response. So with the TP53, although the response rates were not bad, 60-80%, the survival is about 8 to 9 months. And with FLT3, both Dr. Andrew Way as well as our group has shown analysis showing that the duration seems to be shorter. So the high-risk groups are still difficult. They do better than with AZA or DAC alone, but we're not really anywhere close to a home run in those populations, so more research is definitely needed. The survival curve, of course, came later, and people were still holding their breath because we've had a lot of experience with AZA plus drug ABC. We've done it with Revlimid and Vorinostat and Mylotarg, and everything looked very good in the beginning, but the survival didn't pan out, and there have been multiple phase 3s that actually fell after this approach. So here it was nice to see the survival panning out at about 16 to 18 months, depending on the AZA or DAC combo that was used. And of course, the tail of the curve is what patients and clinicians are more concerned about rather than the medians. And here you see a 2 to 3 year follow-up, and now this has been updated. We have about 45-50%, which again, if you look at AZA or DAC alone, was about 15 to 18%. So still not randomized, but very encouraging. And I think in the United States, at least, this has become something that's used very frequently in this particular population of patients. Now, the next slide, I think it's important, and we were discussing this in the break, is that this is not low-intensity therapy like AZA alone. This is not the therapy that you can give and bring somebody back in 4 weeks. And you already heard the discussion from the panel. So one, you started inpatient. I think if you don't have a very big setup that can do labs daily, twice a day, like in the community, my recommendation would be to consider admitting that patient for a few days. And the second is, at least you need labs 2-3 times a day. These people do get cytopenic, they do need platelets, they do need neutrophil support, and you do see febrile neutropenia. As you can see in this slide, 50 to 60% of the patients will have it. It's not as severe as 3+7, it's manageable, but you do need to be aware of that. And we actually recommend dose interruptions. Once you're in remission, you can do 14 or 21 days out of a 28, 35-day cycle, and it seems to be quite efficacious in that approach.